Good morning, everyone.
Good morning, Sarah. How are you?
Good. How are you doing, Sean?
Yeah, I got my Kleenex right here.
Oh,
So
I'm sorry
Oh,
you're sick.
that's all
sorry to
right.
hear that,
Oh,
Sean.
Mr.
That's all
Bridgeport's
right.
calling in a moment.
That's all right. But I'm gonna go ahead on mute. So if just holler in the chat if you need anything. We are open, by the way, so people can start logging into the room. So FYI.
Sean, can you send Mr. Bridgeforth link one more time? This is his email. I'm going to put it in the chat.
Yep, no problem.
Hi, Adelia. Good morning.
All right, I see 11 o'clock on here. Excuse me. We're gonna give about another 5 minutes for everybody to get logged on and to get settled. So go ahead and get yourself a beverage, a refill, go use the restroom, and we'll get started at 11:05. Thank you. All right, good morning, everybody. Still got a couple more minutes here, so we're going to go ahead and start at 11:05. So go ahead and make yourself comfortable, and we'll get started shortly. Thank you. All right, I've got 11:05 on our clock. Sarah, do you want to go ahead and get this party started here?
Sure. If we can take just one more minute, it sounds like we're still having a technical issue with one of our presenters. I just want to make sure that we get them logged in. But good morning, everyone. Thank you to all of those of you who have joined us so far.
Morning.
And we'll go ahead and get started. Okay. Good morning, everyone. Thank you for joining us today for our Lunch and Learn on back pain causes and interventions. I'm Sarah Whitney, and I'm the Community Outreach Coordinator at the Healthier Black Elders Center in Detroit. We'll give a brief introduction of Healthier Black Elder Center before we get started with our presentations. First, we will start with a commercial presentation, and then I'll do some more talking.
Did you know research studies bring about discoveries that can improve health and quality of life? And people of all backgrounds need to be included so that communities can trust and see themselves in the findings. Unfortunately, Black older adults in particular are not often invited to participate in research. We understand that people are mistrustful of research because of the abusive legacy of the Tuskegee study and the use of cells from Henrietta Lacks, among other examples. We're here to share with you that there are several safeguards in place to protect the health, safety, and privacy of participants, including older adults. All studies must be reviewed by a panel of experts at a university called an Institutional Review Board, or IRB. Then, studies that want to work with community members here in Flint can go through additional layers of review by non-medical community advisory boards to make sure they are moral, ethical, and confidential, that they obtain consent and provide clear information on the purpose of the study. Our Healthier Black Elders program in Flint and Detroit helps connect Black older adults with research studies approved by both the University Institutional Review and a community advisory board of Black older adults and aging agency leaders. Some of these approved studies provide compensation to participate. Each one differs, and researchers can tell you more about what their study offers when you sign up. We provide free programming on health and well-being hosted at local senior centers and online with tutorials on how to participate if you can't get there in person. A newsletter featuring community events and community member profiles, research studies and findings, and continuing health education.
Healthier Black Elders need you.
We connect you to research you can trust.
Research development needs you.
If you're interested in learning more about the Healthier Black Elders program in Flint or Detroit, you can visit us online at www.engageus.org.
All right. So that's a little bit about Healthier Black Elders Center. And if you want to learn more about our community and you're not yet a part of the Healthier Black Elders Center, you can certainly join us. You can call us and ask questions, or just decide to fill out our survey and become a member. You can reach us at 313-664-2616. That's our Detroit phone number, and you can join that way. We do lunch and learns like the one today. In the spring and early in the year in January, we will have lunch and learns in person again. We will still have a couple via Zoom, but we'll be looking forward to those in-person lunch and learns where we can bring the lunch piece back. We also host a weekly party line. It's a social hour on Zoom. And you can also call in by phone, and we play games, have great conversations, and just chat. We also send out newsletters 2 or more times a year, if we can manage, containing different articles that share really vital health information about community resources and events. And by joining, you are able to participate in our participant resource pool, and you'll be exposed to different social behavioral research studies that you have the option to participate in if you choose. So before we begin our program for today, I want to get started with a segment called Critical Crossroads. This segment is something that we developed, I think, a year ago now, maybe 2. And this is a committee that's part of our community advisory board, where we have our advisory board kind of discuss social events that impact our health and social phenomena. So we have 3 presenters today who will be talking about the recent election and their thoughts and reactions to it. Our first speaker, we have Henry Swift, and he'll be reading an article that he found that resonated with him. Henry, I'll pass it on to you.
Thank you, Sarah. Can you hear me?
Yes, we can.
Okay. Leonard Pitts is a journalist with the Miami Herald, and he had an article that really sums up where we are as a country. I have never seen America. Yes, like Bruce Springsteen, I was born in the USA. But as I argued before, America is less a place than a set of democratic ideals: equality, self-governance, the rule of law, freedom of speech, freedom of protest, liberty, and justice for all. America is a vision that Americans have struggled and largely failed to realize for 246 years. But if we've never quite managed to bring it more than fleetingly to life, seldom has that vision been more directly threatened than it was in last November the 8th, midterm elections. Hundreds of election deniers were placed on state ballots for such key posts as Secretary of State, U.S. Senator, U.S. Representatives, and Governor. About that election, we can say this: democracy survived. It wasn't pretty, and it wasn't as decisive as one might have hoped. But yes, democracy lives to fight another day. Many of us wondered if it would. We faced the prospect of our government dominated by people whose guiding ethos is that an election
Recent
is not
router
fair
timeout connecting.
unless
just
you
mute
win.
yourself.
That's a recipe for fascism, not democracy. It's also childish in the extreme. If voters did not quite reject that ethos, they did blunt its force. Apparently, we are still deciding what kind of country we want to be, which means there is still time to get it right and also to get it wrong. Troublingly, there's every reason to believe that stakes will remain this high, democracy perpetually on the ballot for the foreseeable future. That can change until and unless the fever that has gripped a political segment of the country finally breaks. Here's hoping. I've never seen America. It's getting late in life for me to think I ever will. But the election results suggest there remains at least a chance my grandchildren will someday glimpse what I did not. I've never seen America, but I think it's worth fighting for just the same. Thank you.
Thank you so much, Henry, for sharing that. To kind of continue on with thoughts on the election, we have Mr. James Bridgeforth. Is he on?
Yeah, I'm on. Can you hear me?
Yes, we can.
I finally got it figured out.
Perfect. So sorry about that.
No, it was my fault. It was my fault. It wasn't yours. Where do we start?
All
You
right,
got
so
the
we have some
slides?
slides here. Yep, can you see the slides?
No. Damn it. Now I lost the whole thing.
We'll reshare them. Okay. Should be able to see them now.
Okay, I'm back, Sarah.
Oh, Okay. I didn't know you had dropped out. Can you see the slides now?
No, I can't. Okay, here we go. Oh, I saw him for a minute. Okay.
There you go.
Okay, I put together two slides primarily to just give us some information about voting patterns in the city of Detroit. And I went to the election, to the internet to try to obtain this data. I couldn't get it from the clerk's office because they wanted $75 for me to come downtown to get it. So anyway, what I want this data shows in terms of the level of participation as a percentage of total registered voters in the elections from 2008 to 2022. And as you can see, it's very anemic. And so we touched on this before, that Detroit is losing its importance in terms of being an important clog in the whole voting process for the state of Michigan. And what I wanted to show here is that we need, as I guess, a Healthy Black Elders group, we need to focus in on maybe talking about how we may be able to influence or stress the importance of people turning out to vote. The other part of this chart that shows you is that one of the significant parts of voting is the primaries. And as you can see, our participation in the primaries are very, very low. The primaries are where where it all begins, and in terms of getting candidates ready for the general election. And except for when 2008 and 2010, 2012, when President Obama was running, our level of participation is very anemic. So one of the things we need to at least encourage in our process and critical crossroad is to try to talk about how we can maybe influence people to come out and vote. Now I want to show you another slide because I only have 3 minutes. I put this slide together to show you that how the population of Detroit is continuing to dwindle. And if you go from 2000, we were 951,270, all the way down to 624,177. Now, this is a product of city government and really not taking responsibility for making sure that the citizens have an environment that they want to live in. So the quick and reflective or reflect action is to blame the white flight. But if you look deeper into these numbers, you see a significant number of Black folks are leaving the city too. And my experience has been over the years that the city government has not been very responsive to the population. It talks a good game, but when you try to get stuff done, it doesn't. You got trash you're trying to pick up. When I call the mayor's office to try to get something done, it's almost like no one is accountable or have responsibility for the people under them. The city council is set up in such a way that everybody is an individual and no one has primarily a direct accountability to the president or anybody else. It's just like a fraternity. So one of the things that I want to take a look at is, as we look at these numbers, is particularly what's going on in Detroit now. And that is the fact that we got money moving into the city. We got a situation going where the money is moving into the neighborhoods, buying up the homes. And so we're going to have people leaving. The other concern I have is that because the city is not responsive to the homeowners, which is a core value of the city, people are just getting disgusted. My friends are disgusted. I'm disgusted with them. And so what I'd like for us to talk about at some day when we have more time is, look, every time when you hear people talk, they're always talking about the so-called downtrodden. They're always talking about criminal justice reform and all of this, but they don't look at how these things that they're talking about affect the people who have the homeowners in Detroit, particularly the seniors. The seniors are concerned about crime. There doesn't seem to be an adequate response to that. So there are a number of issues that I would like for us to look at in future critical crossroads, particularly as it relates to the citizens in Detroit who provide the stability for these neighborhoods. And I don't want to hear no more about the criminals. I don't hear no more about how unfair this is. And I'm concerned about the people who are paying the taxes, the people who are concerned about their homes and trying to keep them up and the responses they're getting. So I think we need to, I would recommend that we start looking at what's happening with seniors or homeowners in the city of Detroit and seeing if there are any opportunities for us to address those issues. So anyway, I think my 3 minutes is about up, but I don't know how you feel about it, but I would like to put that out there using these figures that we begin to talk about what happened to homeowners in the city of Detroit, particularly seniors. Because as more and more money moves into the city, the seniors are going to become more and more marginalized. And so that was my 2 cents there. We got the voting pattern on one hand, because people have this apathy, because the system is not working for them. On the other hand, we got people leaving the city because the system is not working for them. So I'd like for us to talk about that in a future critical crossroad. So that's my 2 cents for today.
Thank you, Mr. Bridgeforth. And we had someone in the Q&A box ask if we can share these charts, and we absolutely can. We can send them out, we can mail them, we can email them, however people would like to receive them. So if you would like to have a copy of these to share with your loved ones, with your community, you can call us at the office, 313-664-2616, and we will make sure to get you a copy of that in the best way that suits you.
Sarah,
For our last piece of critical, yes.
could we put something on a future agenda to talk about the things that I talked about, because this
Absolutely.
is a real concern to me, my friend, because I've tried to get through the city and it just seemed like no one is accountable for anything. We got trash building up in the neighborhood, even in the stable neighborhoods. We're not getting an adequate response, and it's always shoving the buck on down the road. The mayor office is not accountable for anything. The city council is not accountable for anything. And all they do is drink coffee and have meetings and give out awards. But anyway, so I would like to talk about that sometime when we get time, okay?
We absolutely can. I think it's an important conversation to have, and we'll see the best way to have that and then share it with our participants.
Okay. Thank you very much.
Thank you. And next we have Ms. Adelia Cooley to share her thoughts on the recent election. Ms. Adelia, are you there?
Yeah, can you hear me, Vanessa?
We can hear you.
We can hear you.
Vanessa, you can hear me?
That's Sarah.
Yes, we can.
Okay. I apologize for my technical difficulties, but I'm Adelia, and I've agreed to comment briefly on 2 topics. One being what the 2022 election means to us as seniors, and the second topic is why I stay informed as an adult and as a senior. So what does the 2022 election mean to us as a senior? In 2 words, it's complicated. The election was positive for seniors and our senior programs, yet overall, the 2022 election likely means there will be no new initiatives based on older adults that will pass Congress in 2023. While few legislative initiatives are likely, watch for an aggressive ongoing regulatory push on nursing homes from the Biden administration. The Biden administration's ambitious plan to support older adults is dead, at least until 2025. Even as the election results were positive for seniors and our programs, some worry about Social Security amid the debt ceiling negotiation. A divided Congress also means major changes in the Medicare drug costs, but it will survive, at least for now. Once again, seniors and advocates will need to mobilize to protect our Social Security and our Medicare. We need to remind members of Congress that Social Security and Medicare are promises to the American people that should not be broken. The coming battles for us as seniors may be like deja vu for those of us who remember the Obama years, when in 2011, a new Republican House majority tried to force Democrats to accept huge spending cuts, including our senior earned benefits. In conclusion of this topic, it is not a stretch to say that along with sending strong messages about the importance of democracy, our senior citizens and our advocates said loudly and clearly during the 2022 election, hands off our Social Security and Medicare, and that's good news. Just a few reasons why I stay informed as an adult and a senior. Staying informed helps me to make wise and intelligent decisions that can help me decide what's best for me. It keeps me mentally and physically active, providing me with a sharp and active mind, which improves my overall well-being. It helps me make connections needed to improve my quality of life. Staying informed with trustworthy information, it's important to keep myself informed, but it is also important for me to use my good critical thinking skills when consuming information. Staying informed with trustworthy information in turn hopefully will aid in my maintaining my dignity, my independence, and to remain in charge of my activities regardless of my age and my health circumstances. Thank you.
Thank you, Ms. Adelia, and thank you to all three of you, Ms. Adelia, Mr. Jim Bridgeforth, and Mr. Henry Swift.
I have a question for Adelia.
Okay.
Adelia, you know, I was listening to this Georgia results last night.
You were listening to who, Jim?
The Georgia Warnock results.
Oh, yes, yes.
In the background in terms of all of the work that they put in to make this happen. And I was thinking that with the Gen Z group of young people coming along that seem to be more progressive than their parents. And I was wondering if older folks should not perhaps look at putting together some kind of coalition around those people too, because they seem to have some of the more sympathetic kinds of orientation than their forefathers, let's say that. And I'm generalizing, of course. And so I was wondering, as a strategy, what you think about the fact that older adults, seniors teaming up with younger people and making sure that they vote around those issues that are pertinent.
I agree with you totally, Jim. I definitely think there should be some type of relationship with us seniors and the younger generation as it relates to voting in elections, because it would make a lot of difference in getting results.
Can you hear me, Adele? Hello?
Yes, I'm here, Jim.
Mr. Bridgeforth, you're muted. But I will say we are going to need to move on to our next segment.
I just want to make this statement.
Conversation.
And I think we need to tie it into the voting patterns. We can talk about that later, but I like your presentation. Thank you.
Oh, thank you very much.
Thank you to all three of you again. That was wonderful. We're going to move on briefly to our next presentation before the main presenter. We know that something that we've missed out on with the virtual lunch and learns has been the vendor tables and the lunches. And we can't bring you lunch, but what we can do is bring you virtual vendor tables. So we have a couple of folks who are our friends in the community from local organizations to share a little bit about what they do and ways that you can get involved. And we will start with Mr. Carl Wellborn from Independence Rock.
Good morning, everyone. My name is Carl Wellborn, and I am the founder and executive director of a nonprofit ride service called Independence Rides. Our mission is quite simple: to provide dignified rides for seniors and vision impaired adults. One of the most compelling pieces of research behind why we're here is the fact that very few people plan for the time when they will have to stop driving a car, and then how they plan to get around in order to just get general things done. Unfortunately, there are not a lot of affordable and accessible options for seniors needing to get around for basic needs like doctor's appointments and grocery shopping, to say nothing of visiting friends and going other places. So that's why we're here, to provide rides designed specifically for older adults, and to do so in a dignified way. By the way, I apologize for my camera fading in and fading out. I'm sure it's no surprise to you that COVID brought many challenges to us, just like it did everyone else. However, we're still here and slowly digging our way back to full capacity. For example, we've had to stop accepting new members because we're not yet able to meet the demand. We're also limited to only rides for doctor's appointments and grocery shopping since the beginning of COVID. But as I said, we're still here. We're still working to get back to full capacity and to the original vision of providing rides to any destination. To find out more about us, you can feel free to visit our website, which is at www.independencerides, all one word, .com, or just give us a call at 313-618-1578. Thanks.
Thank you, Carl. Next, we have Trina Horton from the Alzheimer's Association. Let me make sure she can speak. Trina, are you there? Hit *6 to unmute. There you go.
Can you hear me, Sarah?
Yes, we can.
Okay, great. Thank you so much for this opportunity. I'm Trina Horton with the Alzheimer's Association Michigan chapter, and our main office is located in Southfield, but we do service the entire state of Michigan. And briefly, I want to just share what our mission is. We are leading the way. You can go to the next slide, Sarah. Sorry if I'm going too fast. What we do. We are leading the way to end Alzheimer's and all other dementia by accelerating global research. So we want to make sure that all groups, all ethnic groups are included in the studies and have access to whatever advances that are made in relationship to Alzheimer's and other dementia. So we want to make sure that we are advocating for all groups, and also driving a risk reduction and early detection. So we talk about what those risks are and maximizing quality care and support through our programs and services. Next slide. And I want to just briefly point out a couple of these things on the chart from our 2022 Alzheimer's disease facts and figures. You'll see that 1 in 3 seniors dies with Alzheimer's or another dementia. Another one that stands out is that it kills more than breast cancer and prostate cancer combined. So that is why we are so involved in research. Next slide. So just a little bit about the risk. Age is the greatest risk factor. There's also family history, heredity, head injury, and lifestyle. So whereas we cannot change our age, we cannot change our family history and so forth, our heredity, but one of the things that we are looking at is the lifestyle. Through research, there are some things that we can do to help lower our risk. Next slide. Black African Americans are about twice as likely to develop Alzheimer's, and Hispanic Latinos are about 1.5 times as likely than whites to have Alzheimer's or other dementias. So that is why we want to make sure that we're getting the word out about some of these risk factors. Next slide is just talking briefly about how we are progressing towards risk reduction, because we're out there in the community, but we do need help to get out there more, letting people know what these risk factors are, and talking about the more effective treatments that are coming down the pipeline. Our next slide just talks about our other locations, but again, we service all of Michigan. So I myself, as well as some of our volunteers, we have community educators and community representatives who are helping us by going out and giving presentations and getting the word out about our services and about ways that we can all get involved. So just a little bit about our programs and services. The next slide lets you know that we do have a 24/7 helpline. We have trained representatives on the calls that can help with resources and information and services and just support, even if it's at 3 o'clock in the morning. So we're grateful that this is available, and we've put the 1-800 number here, 1-800-272-3900. You can email us. You can also visit our website at alz.org. The next slide talks about one of our other services, which is care consultation. We can do that by phone, by virtually, and in person, where we can meet with families, just helping you navigate care plans, planning for the future, and helping caregivers and those diagnosed with support. Our next slide talks about our programs. Again, we offer education programs on various topics. I am happy to come out to your block club meetings, to your church, to any groups, clubs that you might be involved in. We can give these education programs. We also have support groups available and social engagement, where we have partnered with various organizations such as the Detroit Institute of Arts, the Detroit Zoo, the Henry Ford, and many other organizations have partnered with us, where we can take those who are caregiving and their person who's been diagnosed and have social engagement with them. So that has really been a great program. And then the last slide is just showing you how you can get involved if you would like. Maybe you would like to be a volunteer that can help get this word out. We're really looking for health connectors that can help connect us to your community. So again, you are out there in the community, you know people, so you can help us reach more people to bring awareness. And then, of course, we have other ways of getting involved through advocacy. And as you see, we have a walk to end Alzheimer's, like many other nonprofits do, because we do need the funds to be able to provide the free services. So there's many ways that you can get involved if you so desire. And I thank you so much for your time. You can reach me, Trina Horton, at thornton@alz.org, or you can call me directly at 248-996-1058. Thank you so much for your time. Thank you, Sarah.
Thank you, Trina. All right, and so for our last virtual vendor, we have Vanessa Rorai, who will be recruiting for a study.
Thanks, Sarah. I'm going to be 1 minute or less. That's my goal. So
All
some of
right.
you,
Thank you.
some of you may recognize my name. Majority of my job at the Institute of Gerontology is coordinating the Healthier Black Elder Center with Sarah. And then I also work on coordinating a separate research study called the Wallet Study. And with the Wallet Study, the reason why we started this was because rather recently there was a pretty large study that came out and showed that when individuals have a change or decline in their memory or thinking skills, there also tended to be a loss of wealth. Now, unfortunately, this large study didn't go enough into detail to really tell us why this loss of wealth was occurring, how, where the money was going. So we designed the Wallet Study in a very particular way to try and answer these detailed questions. So we're hoping with this, we can create a best practice of how to analyze older adult finances. We're hoping we can create a list of warning signs or red flags that would indicate that someone's at risk of losing wealth. And then once we have this list of warning signs, we're hoping to create a best practice of how to intervene beforehand to protect older adult finances. So we're hoping to achieve these goals through 2 telephone interviews. Everything about the study is done remotely, so everything is done by telephone and mail. And then we're also asking participants to provide a copy of 12 months worth of bank statements. Now, the bank statements are completely de-identified. That means we remove any information that could identify you in some way. And we have very strict protocols of how we have to handle your statements. Then there's 2 benefits of participating. First one's compensation. Anyone that participates and completes the entire study is compensated $100. And then we also have a program at the Institute of Gerontology called SAFE, which is Successful Aging Through Financial Empowerment. And anyone that participates in our study, if we think it could be helpful or relevant for further support from the SAFE program, we'll definitely connect you to that resource. But again, that's if it makes sense for you. So we are looking for individuals age 60 or older to participate. If you have any questions or you're interested in participating, you can give me a call at 313-664-2604, or you can send me an email. My email is V as in Vanessa, RORAI@wayne.edu. Thank you so much.
Thank you, Vanessa. And thank you again to all of our presenters so far. We really appreciate you being here this morning. And again, if anyone is interested in any of the things that you've just heard and you didn't catch all the phone numbers or you just want to ask more questions, you can always use our HBE phone number as a central place to get information. That's 313-664-2616. Okay. And now we're going to begin with our main presentation. Thank you all for your patience with our technical difficulties, and I hope that we don't have any more. Our speaker today is Dr. Harvey Echols. Dr. Echols is a licensed physician and surgeon with over 30 years of experience in many fields of medicine, including managed healthcare, Medicare plan administration, general medicine, sports medicine, occupational medicine, urgent care, utilization review, phlebology, medical legal consulting. He is a jack of all trades when it comes to medicine. He recently accepted a new role, and I'll let him share a little bit about that. But he is also my dear cousin, and I'm so grateful to have you here again and to be related to such brilliant people. Dr. Echols came in February and talked with us about how to stay fit after 50. And now he's here to talk with us about back pain. So I will give the floor to you, Dr. Echols. Thank you for joining us today.
You are so welcome. I am thrilled to be here. I'm going to make the assumption that everybody can hear me.
Yes, we can.
But speaking of technical difficulties, I need to figure out how to get the slideshow started.
Okay. Let's see.
Okay, all right. I think I've got this, so let me share that. And
okay.
You can
Got
see
it.
the slideshow.
Yes, we can.
Outstanding. Okay.
Perfect.
So as Sarah pointed out, I am first and foremost her cousin, which is a pretty popular thing to be these days. And she ran down quite a few of my myriad of jobs. The position I have accepted recently, I am leaving the world of administrative medicine and going back into the world of clinical practice. I have been a phlebotomist in the past, and a phlebotomist is not a person who draws blood. That is a phlebotomist. A phlebologist is a person who repairs varicose veins. And so I am going back to repairing varicose veins. And Sarah, I'm certainly available in the future if you'd like to have a discussion or like me to give a discussion on varicose veins, what causes them, how we treat them, what to do about them, et cetera, et cetera. We can talk about that later.
Awesome.
In any event,
congratulations again.
Well, thank you. I'm pretty pleased to do that. Let's talk about what's going on back there. And I would encourage you, if people have questions, feel free to holler out, or certainly there will be some time at the end here. Common causes of back pain. Everyone's had it. Let's talk about why you have it. And I'm going to assume that most people can see the slide presentation. If there's anyone who cannot see it for whatever reason, I'm going to attempt to talk through it a little bit, but it certainly does help if you can see the pictures. The most common cause of back pain is muscle strain. The most common strains affect the lumbar area, which is the lower back area. Everybody either has or knows somebody who has bent over and said, "Oh my God, my back," and grabbed their lower back. This can be caused by stretching and bending in abnormal ways that cause muscle tearing. Obviously, pain can be chronic or acute. The initial treatment for this is progressive activity. It is not bed rest. It is not stopping. It is actually more movement. Medication, generally over-the-counter medication will work fine. Over-the-counter being ibuprofen, Advil, and alternating heat and cold treatments. The very best thing to do is to start with heat and end with cold. And so you alternate that, and I like to call that my rule of threes, where you give 3 minutes of heat, then 3 minutes of cold, 3 minutes of heat, 3 minutes of cold, 3 minutes of heat, 3 minutes of cold, 3 minutes of heat. Finish that with 10 minutes of cold. And the reason why you finish with cold as opposed to finishing with heat is because heat feels better, cold is better for you. What the heat does is brings blood to the area. And as the blood comes to the area, it brings all kinds of healing elements that you would expect in the blood. Applying the cold acts as squeezing of a sponge, and it squeezes the blood out of the area. If you use the heat and don't use the cold, what you're going to wind up with is a back muscle full of blood. And as that muscle begins to cool off by itself, it goes into spasm. And we interpret that spasm as pain. So rather than just sitting on a heating pad, and if you've ever done this, I'm sure you've noticed, you sit on a heating pad for a while, you stand up and you feel better for about 10 minutes. And then all of a sudden the pain comes back, and it comes back with a vengeance. And the reason for that is because you've got all this blood now in the muscles, and the muscles can't do anything with it. They go into spasm, there's your pain coming back. So always in your contrast therapy, which is what we call it, heat, cold, heat, cold, heat, cold, always end that with cold. Now, as you're looking at the picture on the slideshow, you will see two muscles that are attached to the spine. Those are the psoas muscles, P-S-O-A-S, psoas major, which is the bigger muscle, and you'll see that on the to your right, and the psoas minor, which is the smaller muscle. On the left side of the screen, you only see the psoas major muscle. But those are the muscles of the lower back. Those are the muscles that flex the hip joint. In other words, that's what allows you to bend over, or that's what allows you, as you're in the sitting position, to lift your upper leg, lift your knee up toward your head. A common example of the movement created by this muscle is walking or biking. So when that muscle goes into spasm, that is the most common cause of lower back pain. That muscle is buried deep. As you can see, it's placed in front of the pelvis, so it's not an easy muscle to get to in terms of treatment. That's the reason why activity is so important in terms of exercising this muscle. What's the best activity? Walking. If you can get on a bicycle, get on a bicycle. If you watch the NBA or you watch the NFL, you'll see players who are injured, and when they go off to the sideline, what do they have them do? They have them get on an exercise bike. The reason for that is so that you can keep that muscle warmed up, keep that muscle stretched out, and stop the spasm of that muscle. Moving on, second most common low back problem, spondylosis, which is a fancy medical term for spinal arthritis. The discs, excuse me, are soft, spongy material between the vertebrae. Lumbar spine arthritis accounts for as much as 85% of back pain felt by Americans. So as you're looking at the picture, you can see all the way at the top a normal disc. The cushion spaces, the discs between the vertebrae, thin as we get older. They tend to lose fluid content. So what you're most familiar with as you age is gray hair and skin that has a few more wrinkles in it. Well, that happens because the skin and the hair lose fluid content. What you're not aware of is the discs losing fluid content. But as the discs lose fluid content, the vertebrae tend to get closer together. Each one of those vertebrae and disc is a joint, just like your knee joint, your ankle joint, your shoulder joint. You have independent movement at each one of those vertebrae. So as those vertebrae are moving and coming in contact with the vertebrae above it or the vertebrae below it, you have rubbing of the bone because you've lost disc height. And when that happens, you wind up getting arthritis. As I say, the cushion spaces between the vertebrae get thinner and bone spurs begin to form on the joints, and those cause pain and stiffness. So as you look at the drawing again, you'll see at the top, you'll see a normal disc. All the way at the bottom, you see disc degeneration with osteophyte. Osteophyte's a bone spur with osteophyte formation. Again, there is no cure for arthritis. Basically, you can think about a bone spur as being a scar on the bone. So if you've ever had any kind of an injury before on your skin, you've got a scar. Can we remove that scar? We absolutely can. What are we going to leave in its place? Another scar. So you can't get rid of it. It's just part of your badge for being the age that you are. Well, the spinal arthritis is the same way. There's no cure for it because if we were to remove those bone spurs, we will develop more bone spurs, assuming we could get to that area, which again is not the easiest thing to do. So because of that, the standard treatment for spinal arthritis is self-care, medication, again, the most common, ibuprofen, Advil, or whatever your anti-inflammatory medication of choice is, physical therapy, and on occasion, acupuncture. I have had acupuncture myself, and I'm not a big fan of getting stuck with a lot of needles, but on the other hand, it did work in terms of decreasing some of my knee discomfort. So I am a proponent of acupuncture for treatment of chronic pain. Next most common, scoliosis. Many people associate scoliosis, which is curvature of the spine, with children and back braces. But according to a 2005 study, scoliosis is prevalent in as many as 60% of adults above the age of 60. And you can see here in the top drawing, you see the natural front to back S shape of the spine. You have curvature through the cervical region, which is the neck, the thoracic region, which is the chest, which is the opposite curvature, the lumbar region, which is the lower back, which has the same curvature as the neck, and then the sacral region, which has the same curvature as the thorax. So you can see the characteristic S curve of the spine. The drawing at the bottom shows you what the C shape of scoliosis looks like in a patient taken from the back. And so you can see you can have scoliosis or spinal curvature in one or more areas of the spine. And this can occur for a variety of reasons. It can occur as a result of trauma. It can occur as a result of physical situations. Let's say you find yourself, the particular job you have requires you to bend in a particular position for a long period of time, and you hold that job for a long period of time. Eventually, the muscles on one side of the body are going to get weaker. The muscles on the other side of the body are going to get stronger. And if you continue to do that without correction, then you may well wind up with scoliosis. Not necessarily to the degree that you see on the pictures here, but you can wind up with some level of scoliosis. This reflects itself in terms of pain with simple activities, including standing or walking. And again, as I pointed out with my employment example, the discs and joints shift, and those will cause imbalances that show as either leg pain or back pain. The primary treatment here is physical therapy, because what we need to do, unless this is severe, then we need to improve back dynamics so that we can begin to stretch out the short side muscles and shorten the long side muscles. So we'll do physical therapy, we'll do anti-inflammatory medication, and simple exercise. On more severe forms of scoliosis, surgery can be an option, but that isn't typically done on adults because as you develop scoliosis as an adult, it's amenable to physical therapy and exercise. You don't typically get such severe scoliosis as an adult that surgery is required. That typically is required in children who are born with it or who acquire it at a relatively early age, but not quite so much as an adult. Everybody's favorite, herniated disc, or you may have heard this referred to as a slipped disc. And again, as I explained before, discs are jelly-like cartilage that prevent bones from rubbing against each other. Due to injury or wear and tear, again, the process of aging, that cartilage can rupture and it applies pressure to the nerve root, causing back pain. As you're looking at the picture on the top shows you a normal disc, degenerative disc, bulging disc, herniated disc, thinning disc, and I've spoken of the thinning disc before, and disc degeneration with osteophyte formation. As you look at the picture on the bottom, that is a picture, if somebody were to look at your spinal cord, looking down on you through the top of your head, you can see what your spine looks like. And so on the left side of the picture, you can see a regular disc. On the right side of the picture, you can see a disc herniation. The disc is composed of two different forms of cartilage. The outside is called the annulus fibrosus. Annulus, annular meaning year. So think about if you cut a tree in half and you can tell how old the tree is by counting the rings. You don't have rings in your spinal cord, but that gets a little bit bigger every year. That's why it's called annulus. Fibrosis, fibrous, very, very tough. So the outside of that disc, the darker pink part, is the annulus fibrosus. The inner lighter pink part is called the nucleus pulposus. Nucleus, inner, pulpy, softer. So it's much softer. If you think about they used to have this gum on the market. Oh, 20 or 30 years ago, you'd bite into the gum and the squishy flavor would come out on the, that was on the inside. That's what this is like. The nucleus pulposus is there to offer shock absorption so that your vertebrae can bounce up and down on each other and absorb the shock of walking or running or falling or whatever. Again, injury, wear and tear, that cartilage ruptures. If the annulus fibrosus, the outer part ruptures, then the inner part pops out. And you can see that in the picture on the right. Also, in the picture on the right, once that area has popped out, it's rubbing against a nerve root that's coming out of the spinal cord, that's coming out of the spinal canal. And that's where you get the pain. Typically, if it happens in the lower back, you get the pain of sciatica. Sciatica occurs when the nerve root is so irritated that you'll get shooting pain or numbness that affects one or both legs. I didn't include sciatica here in common back pain because it's not as common as you might think. But the other reason I didn't include it is because sciatica itself is not back pain. Sciatica tends to be more leg pain, but it's caused by a disc herniation in the back. There are people who have disc herniations that require medication or surgery, but again, treatment, primary treatment is rest and physical therapy techniques to strengthen the back. A good way to think about this is think about an Oreo cookie where the two cakes of the cookie are your vertebrae and the stuff in the middle is your disc. If you squeeze that cookie together, the stuff in the middle is going to pop out the sides. That's what happens with a disc herniation. If you pull the two cakes apart, then the stuff gets kind of sucked back toward the middle. That's where the exercise comes in, because you have muscles attached, multiple muscles attached to your vertebrae. As you strengthen the lower back muscles, it pulls the vertebrae apart and the stuff, the disc, gets pulled back toward the inside, and you can reverse some of the effects of a bulging disc. You can't always reverse the effects of a herniated disc, and you can see the difference in the top drawing. A bulging disc, if we can pull the vertebrae apart, we can get rid of the bulge frequently. With a herniated disc, that may require surgery if we're not able to pull that apart simply by using medication and physical therapy techniques. Osteoporosis causes bones to become weak and brittle, so brittle that a fall or even mild stresses such as bending over or coughing can cause a fracture. This occurs, and it occurs less in African Americans than it does in Caucasians. Let me back up and say that again. It's less in people of color because it's not just American. That has nothing to do with it. It occurs less in people of color than it does in Caucasians. And we don't completely understand the reason why, but it does occur in people of color. So it's certainly something for which you need to look. Aging causes loss of bone mass. As you lose bone mass, this results in height decreases and loss of bone strength. So again, I'll refer you back to the discs and back to the vertebrae. As you age and lose bone mass, your vertebrae tend to get more compressed. And that's the reason why you may have started out in the prime of your life in your 20s at, let's say, 5'9", which is what I started out as. Right now, I'm probably 5'8.5" because I've lost some bone mass. I've lost some fluid in my vertebrae. So I'm sorry, I've lost fluid in the disc. So as we lose bone mass, we lose height, we lose bone strength. And as we lose bone strength, what you will see is a change from normal bone density. Again, the picture on the top left is normal bone density. The picture on the top on the right is osteoporotic bone density. The picture on the bottom shows you actively what this looks like. And you can see healthy bone has much more bone mass, much fewer air cells. Osteoporotic bone has more air cells, less dense bone mass, and then severe osteoporosis has great big gaps of air. And it stands to reason if you've got great big gaps of air and less bone, those bones are going to be more brittle. This leads to breaks becoming much more likely, and the pain caused by the fractures may be compounded because your body has to make adjustments to compensate for the damage. A good example of your body adjusting, not necessarily to osteoporosis, but let's say you have one bad knee, not both, just one. You are going to change the way that you walk to compensate for the one bad knee that you have. That's going to change the way that you put weight on your feet, and you may wind up within a couple of 3 years having a callus on the foot that you're putting more weight on because you're putting more and different weight pattern on that foot. So now you've got foot pain in the foot opposite the bad knee that you didn't have when both knees were good. So that's an example of why pain caused by fractures, or that's an example why pain period can be compounded because you've made adjustments to compensate for the initial damage. What's really important to know about osteoporosis is once bone loss has occurred, you do not ever get that bone back. So treatment is paramount. I would encourage everybody, especially women who are past childbearing years, take vitamin D supplementation, take calcium supplementation, talk to your doctor, because we can stop osteoporosis where it is, but we can't get back the bone that we've already lost. So the really important part about treatment for osteoporosis is stopping or slowing down bone loss. And we do that through, again, calcium, vitamin D supplementation, and medications if it's gotten particularly severe. The reason why I encourage especially women is because the sex hormones are really, really important in terms of maintaining bone density. And men tend to lose their sex hormones. Our testosterone level drops precipitously above the age of 60. It's going down from our 20s, but it drops precipitously above the age of 60. But for women, as soon as you go through menopause, and when you stop having periods, the good news is you stop having periods. The bad news is the reason you stop having periods is because of the sudden loss of estrogen production. And once you have that sudden loss of estrogen production, you then are a prime candidate for osteoporosis because, again, testosterone and estrogen provide bone protectivity. When you no longer have those, you become at much greater risk for osteoporosis. Then we have spinal stenosis, which is a narrowing of the spinal cord. And again, I'll refer you to the picture on the top, which is what you would see if you looked at somebody's spine directly from the top, looking straight down through their spine. And if you look at the picture on the right, you'll see an open spinal canal. If you look at the picture on the left, you'll see spinal stenosis, where because of injury or because of trauma or any of a number of other reasons, heredity has something to do with this, the spinal canal becomes significantly smaller. As the spinal canal becomes significantly smaller, it may rub on the spinal cord. And you see on the picture on the bottom what that stenosis looks like. So the spinal canal becomes smaller, it rubs on the spinal cord, and as a result of that, you may get pain, numbness, or weakness in arms or legs or both because of the spinal stenosis. Approximately 8 to 11% of US adults 50 and older develop spinal stenosis, again, stemming from spinal injuries, herniated discs, or other issues. The most common area where this occurs is the lumbar region, again, the lower back region, but it can occur anywhere. And again, treatment to relieve pain range from analgesic medication, again, anti-inflammatory medication, or usually in spinal stenosis, anti-inflammatory medication doesn't completely do the trick. So you may progress to Tylenol 3 or hydrocodone or something along those lines, to surgery if, number one, we cannot get the medication to work, or number two, your symptoms progress. Spondylolisthesis, and there are 4 grades of spondylolisthesis. Spondylolisthesis may occur because of, again, spondylitis, which is lower back arthritis, or trauma. And what happens here is the part of the lumbar vertebrae below slides forward. So you should have a natural progression. If you look at the drawing all the way on the top on the left, each vertebrae is in line with the vertebrae above it. If you have a vertebrae below that slides forward, that's what's called spondylolisthesis. Grade 1 is a 25% shift of the vertebrae below. Grade 2, I'm sorry, up to 25%. Grade 2 is between 25 and 50%. Grade 3 is 50 to 75%. And grade 4 is greater than 75% slippage. Grades 3 and 4 are going to require spinal fusion surgery. As you can imagine, looking at the picture, those are significantly painful. They don't generally tend to lead to paralysis of the lower extremities when they occur in the lumbar area, because most of the nerves that would be affected have already exited the spinal cord somewhere between the neck and the mid-back area. But they can. And as the slide points out, many issues, including osteoporosis, make the spine so weak that the discs slip out, leading to muscle strain and spasm across the lower back and hamstrings. Management depends on the grade of the slip, but as I said, grade 3 and grade 4 spondylolisthesis, especially with patients in severe pain or who have an inability to function, may well require a spinal fusion. As well, even if you have grades 1 or 2, but there's no improvement after 3 to 6 months of non-surgical treatment, surgery may be a reasonable option. There are patients who require immediate medical attention, and those are patients who experience neurological problems, progressive leg numbness or weakness, and or bowel or bladder dysfunction. Those situations are rare, but they do occur. They are more rare in terms of a progressive degeneration. Usually, if you see somebody who has a grade 3 or a grade 4 spondylolisthesis, that has occurred as a result of trauma. Get in a car accident, get hit by a car, fall off a building, fall off a ladder, something along those lines. That's typically where you will get grades 3 and 4. Grades 1 and 2 may well occur just as the normal result of aging and weakness of the spine, weakness of the discs, again, spondylolysis, as I spoke before. Osteomyelitis is bone infection. And again, this is not that common. Osteomyelitis can be relatively common in the feet, especially in diabetics. So if you're diabetic and you go to your doctor, and every time you go to your doctor, they say, do you check your feet every day? The reason why they ask you to check your feet every day is because, to go off a little bit on a tangent here, diabetes, you think about it as a disease of just high blood sugar, but it's actually a disease of the nerves. And so if you have diabetes, you tend to have degeneration of the peripheral nerves. Where are nerves most peripheral? In the feet. Those are the nerves that are farthest from the nerve center, which is the brain. And so as those nerves degenerate, you may step on a nail or a rock or a needle or a tack, and you don't feel it because your nerves have degenerated. Well, once that happens, you have the opportunity for an infection to get into the foot, and it can attack the bones because you didn't feel it. You didn't see it if you're not looking at your feet every night. So check your feet every night if you're diabetic, because the last thing you want is a bone infection or osteomyelitis. Now, for our purposes for this discussion, osteomyelitis is 3 to 5% of all, vertebral osteomyelitis is 3 to 5% of all bone infection cases. It generally occurs in the lumbar spine, although it can occur really anywhere in the spine. What causes it can be bacterial, viral, or fungal. The most common organism that causes bone infection is Staph aureus, Staphylococcus aureus, which is the most common bacteria located on the surface of the skin. So it's not abnormal for you to have Staph aureus on your skin at all times. We all do. What is problematic is if you aren't washing an area of injury sufficiently, then Staph aureus is an opportunistic infection. It can climb right into that area where the skin has been broken, and the next thing you know, it gets to the bone. As you see on this picture, the small green area all the way to the left side is the beginning of an infection in the bone. The infection finds its way into the bloodstream. This can happen after certain spinal procedures. It creates inflammation, and then it begins to destroy bone and tissue. Depending on the infection, surgery may be needed to remove or replace infected bone. IV antibiotics are not only standard treatment, they are necessary treatment. So if you wind up getting osteomyelitis, you are going to have IV antibiotics. That doesn't necessarily mean that you will be hospitalized, but certainly you may have outpatient treatment where you get an infusion of antibiotics. A nurse will visit the home once a day and give you your IV antibiotics. You simply cannot get enough antibiotic into your system just by taking medication orally, so it's got to get directly into the bloodstream. As you look at the picture, you'll see the picture on the left, the small green area is an infection in the bone. That's the osteomyelitis. If that is left untreated, the middle picture is infection of the disc. And so now you have osteomyelitis and discitis. And if that's left untreated, the infection can spread to the spinal canal. And now you've got meningitis. And that's a significant problem, as you can imagine. So get to it early. It will let you know early that it's there, because this is painful. And that's the thing that brings most people to the doctor, is not the cut, but when you can't tolerate the pain from the cut, you come see me. Once you come see me, then we can adequately and effectively treat it. Now, the next slide is one that is one of the most common. I did these a little bit out of order. My last slide here is one that is very, very common, but I left it to the end because I thought this might stimulate the most conversation or the most questions. Obesity and back pain. Obesity brings with it the greatest risk of back pain, specifically in the lower back for at least 1/3 of the people. And you can see why as you look at the picture. The risk for developing lower back pain is directly correlated with a person's body weight. As you begin to gain weight, decrease exercise, begin to gain weight, where do we gain weight? We gain it in the hips and we gain it in the stomach. Carrying excess weight in the abdomen and pelvis, hips and stomach, is most problematic because it shifts the pelvis forward, putting excess strain on the lower back. And as you look at this picture, if you remember the normal curvature of the spine, the neck and the lower back both curve in the same direction. The thorax or the chest and the sacrum or the buttocks both curve in the same direction. So you have that natural S curve. Now, if you look at the picture, you can see that your lumbar curve in this picture is exaggerated. And the reason it's exaggerated is because in this person, they have excess stomach mass, which is pulling the spine forward. As you pull the spine forward, there's a greater torque load on the intervertebral discs, and that causes pain. As well, when you have significantly more weight in the stomach, excess body mass causes a direct compressive load on the spine. So you're smashing the discs. And again, we get back to the conversation that the early part of the discussion we had, where I mentioned the discs getting smaller. As the discs get smaller, the vertebrae come in contact with each other. That's what sets up the arthritis. Arthritis, we can't cure. We can treat, but we can't cure it. So the answer to stopping a lot of back pain is regular exercise. Get on a maintainable weight loss and exercise regimen. Walk every day. Watch what you're eating. I'm not telling you anything new. I'm not telling you anything that your doctors haven't already told you. But this is the reason why, is because what you don't see is, I've got back problems. What's causing this? I haven't injured myself. Well, you have, but you're injuring yourself a little bit every day just by getting a little bit bigger every day and not exercising every day. And you can see the stress that weight gain and lack of exercise places on the back. And once that starts, it's a cascade that just gets worse and worse and worse over time. And I'm happy to entertain questions if anybody has them.
Okay. So yes, we have questions. The first one that we got was, who should you be seeing when you're experiencing back pain? Do you go to your primary care physician? Do you go to a specialist? And if so, what kind of specialists should you see?
I would recommend going to your primary care physician. Again, I would say that probably 90% of all back pain can be appropriately managed by a primary care physician. There's going to be 10% of back pain, which is not going to be able to be managed by a primary care physician, but let them refer you to an appropriate specialist. An easy way to think about this is, who do you take your car to? Just your guy. When your car is having a problem, you go to your guy. And then you let your guy figure out, oh, no, you need a transmission specialist, or, oh, no, you need a flywheel specialist, or, oh, no, you need a differential specialist. You don't make that diagnosis yourself. You simply take your car to your guy, and you let your guy figure out where the car should go if he can't fix it. Your body's the same way. Your guy or your lady is your primary care physician. So you take your body to your primary care physician. If they cannot figure out, or if they are unsuccessful treating it, then let them figure out the appropriate specialist to refer your body to.
Ah, okay, that makes sense. We saw another one pop in the chat here. Do you recommend back braces for obesity back pain?
I'm sorry?
Oh, do you, we have a question in the Q&A, and it says, do you recommend back braces for obesity back pain, obesity-related back pain?
That's a tough question to answer. And the reason it's a tough question to answer is because I can't make that recommendation without seeing a patient. So back braces may well work, but why are we using the back brace? If it's simply a matter of obesity and there's no problems other than the patient's overweight, then I don't necessarily recommend a back brace. I recommend losing weight. And a back brace isn't going to help with weight loss. The other reason why I hesitate to make a blanket recommendation for a back brace is because your body will adjust to whatever conditions in which it finds itself. If you're using an external back brace, your body realizes, hey, we've got something holding us up. So the muscles that it would ordinarily use to hold itself up, it doesn't use anymore. So chronic use of a back brace may lead to muscle weakness, which is not what we're trying to do. anytime we're using a brace, we're using a brace to supplement the muscles that we already have, that are already present. So my first recommendation would be, what can we do to strengthen the muscles? Which is why I said numerous times during the course of the presentation, physical therapy, exercise, because that's what's going to strengthen the muscles. Simply using a back brace without physical therapy or without exercise to strengthen the muscles defeats the purpose of using the back brace.
Makes sense. Thank you. Oh, we
But
got
again,
another
I
question.
refer you back to go see your regular doctor, because that's not a question that I can completely answer without examining a patient and finding out what's going on. Are you, did everyone in your family have a bad back? What's your bone situation? I need to know all of that information. So that's not a question that I can just completely answer without knowing any patient background or without an examination.
So we won't ask you to do any diagnostics today. But we do appreciate the information, definitely. We have a message, great presentation, very informative. Can we get a link to your presentation? I'm guessing this is asking if we can have a copy of the slides to share with.
Absolutely, yes, I will send those to you as per usual. I will send those to you along with my information, and yes, I'm certainly happy to share that.
Thank you. We have another one. Okay, I said, okay, good. Thank you. Excellent presentation. We have another question here. I think you went over it briefly, but if you could talk again about what kinds of supplements or vitamins we should be taking to protect our muscles and our bones, and to prevent things like bone loss or bone mass loss.
So this is tough to do this time of year if you're in Michigan. Sunlight. Sunlight is, your body will generate vitamin D if you're exposed to sunlight. So get outside once a day, get out into the sunlight so that your body can begin generating vitamin D. As well, you may want to take a vitamin D supplement. Milk works very, very well. That's difficult if you have lactose intolerance. Again, did I mention go see your primary care physician? I did mention that. That's why. So milk as a vitamin D supplement, sunlight as a vitamin D supplement, calcium as a dietary supplement. And again, go see your primary care physician, because your primary care physician is able to do testing to determine if you are vitamin D deficient. That is not something that you can do by yourself. It's not something you can do at home. There are certain procedures and certain equipment the doctors can use to determine whether or not you're losing bone mass. There are medications that can be prescribed for people who do have osteoporosis. But again, and I can't say this strongly enough, you can't replace lost bone. So once the osteoporosis process starts, you can stop it where it is, but you can't go back and get what you've lost. So regular visits to your primary care physician, vitamin D supplementation, and calcium supplementation.
Excellent. And then how, if you can speak on this, how would you identify a good supplement versus something that won't be that great of a quality? Like identifying a good brand to use or a trusted source for learning how to identify a good supplement.
The United States Pharmacopoeia, which is US PHARMACOPAEIA, the US Pharmacopoeia, is going to list every medication, every drug, every, and they do that without, it's a governmental entity. And so they do that without ads, basically. the good part about vitamin D supplementation, what's your favorite milk or what's your favorite yogurt? That's going to give you the vitamin D that you need. Honestly, you can get calcium supplementation by taking Tums. There's enough calcium there. If you're taking a regular multivitamin, that should have enough calcium in it for most people. If you are an osteoporotic patient, then I would again refer you back to your primary care physician, because they may make recommendations as to different medications that are specifically for patients in danger of bone loss from osteoporosis. But it's hard to get a bad calcium supplement or a bad vitamin D supplement for that matter.
Okay. Very good. Well, that makes it easier. But you're right, with the sunshine situation here in Michigan right now, it being one of those very gray, gloomy days, we're all needing a little extra.
Well, one of the treatments that I could recommend for that actually is move to Florida.
Ah, yes. Okay. Okay.
So, I can't tell you how to do that exactly. But they got a lot of sunshine down in Florida. Move to Florida and get all the sun you need.
Oh, we have another question. Sciatica, is surgery ever recommended?
Say that once more.
Sciatica, is surgery ever recommended?
If it does not respond to a variety of medications, anti-inflammatory medications, sometimes short-term, short-course steroids, and physical therapy, depending on the reason for it. So again, disc herniation, it isn't that surgery is indicated for sciatica. The sciatica is the unfortunate sequelae to disc herniation, where the disc is rubbing against one of the nerves that goes down the back, comes out of the lower spine and goes down the back of the leg. So the surgery isn't indicated for sciatica. The surgery is indicated for the disc herniation, which will resolve the sciatica. But it's not the first treatment of choice. It's generally the last treatment of choice after oral medication, physical therapy, oral steroids, and then perhaps even injected steroids. And if none of that works, then we may consider surgery. But surgery, getting cut, is always the last option. Sometimes it's the first option because of the nature of the injury, but opening up a patient is always the last thing as physicians we want to do.
Okay. Are there any other questions before we wrap things up? I know we've gone over our 12:30 mark, but we had a really good conversation going here and I'm getting a lot of good information. Give another moment. Remember, the Q&A box is there at the bottom. Okay. Well, we want to thank you, Dr. Echols, for coming again and joining us at Healthier Black Elders Center you're in sunny Texas right now, right?
Well, I'm in Texas, not so sunny, but yes, I'm in Texas.
Well, thank you for joining us all the way from Texas.
Happy to be here.
And giving such a wonderful presentation, such great information. We always love to have you, and again, welcome you back anytime. And we want to thank all of you for attending today. Thank you for taking a couple hours out of your busy schedules to log in and join us at Healthier Black Elders. Again, if you want to sign up, or if you just want to learn more about what we do and who we are, you can call us at our office in Detroit, 313-664-2616. When you become a Healthier Black Elders Center member, you receive our biannual newsletter and any other mailings that we send out throughout the year. You learn about research studies, like the one that you heard about today from Vanessa. And you learn about future programs like this one, of course. And then speaking of future programs, we have one coming up, and this one will be on January 19th, 2023. So that's welcoming in the new year with our first Lunch and Learn, and it will be in person. And that will be at the Stoudemire. The Stoudemire Center is in the Eastside Community Network. And the topic is the aging brain, what's normal versus what's a warning sign. Again, that's on Thursday, January 19th, 2023, from 11 a.m. to 1 p.m. at the Stoudemire. And the address is 4401 Connor Street, and that's in Detroit, Michigan, 48215. There's free gated parking behind the building. If you would like to attend this event, please RSVP ahead of time. I think we're taking RSVPs up into January 13th. So you can do that by either emailing Vanessa, that's VRORAI@wayne.edu, or you can call us at the center. Again, our phone number for the 1000th time, I'm sure I keep saying it, 313-664-2616. Thank you again, everyone. Happy holidays to you all. Stay warm, even though we're having some unseasonably warm weather. I'm sure it'll turn eventually. And stay safe, and we'll see you all next year. Take care.
Thank you.